Hello and welcome to another intensivecareathome.com YouTube live stream. It is episode 2 of our live stream pediatric services. And today I want to talk about NDIS for pediatric tracheostomy, funding your child's care at home, level 2 and level 3 NDIS support coordination, plan building, appeals, and expert advocacy. So that's what we want to talk about today. My name is Patrick Hutzel. I'm the founder and managing director of Intensive Care at Home. I'm a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager in intensive care for over 5 years. I was part of setting up Intensive Care at Home successfully in Germany in the early 2000s, having brought this concept here to Australia in 2012 successfully. That's how long we've been operating here and successfully in Australia. We are the only provider in Australia that is third-party accredited for intensive care at home nursing. We are the only provider that has the policies, procedures, the intellectual property, and more importantly, we have the team that can bring intensive care into your home. We're employing hundreds of years of intensive care nursing experience combined. No other provider brings that level of expertise into the community in Australia. So today, once again, we want to cover episode 2 of our pediatric series, live series. We're going to do a deep dive into NDIS specifically for families with children who have tracheostomies, who are ventilator dependent, who need high-level nursing care at home. Over the next roughly 45 minutes to an hour, we are going to break down exactly how the NDIS works, what level 2 and level 3 NDIS specialist support coordination means, how to build a plan that funds your child's care at home, the biggest mistakes families are making when applying, and how to fight back when your plan isn't adequate. Now, today's session is not only for families of children with tracheostomies. It's also a session for NDIS support coordinators. Even though I'm not an NDIS support coordinator, we do have our own level 2 and level 3 NDIS support coordinators. And we have worked with many wonderful NDIS support coordinators over the years. But we also know that there's a big knowledge gap when it comes to intensive care at home nursing, how to go about NDIS funding. There's a big knowledge gap even with some NDIS support coordinators. And I believe you are able to learn today as well. And before we go any further, if you're watching this right now, please do 3 things. Hit the subscribe button of my YouTube channel, hit the like button, hit the notification bell, and share this video with anyone that can benefit from today's video if they have a ventilated or tracheostomy child. Even if they are ventilated or tracheostomy adult family member, you should watch this today because you'll learn something. I release free clinical education for families every week on my channel here. It's all related to intensive care at home and families in intensive care. And drop your comments below. Let me know what you think about today's presentation. Let me know what content you want me to create. Let me know your questions so I can answer them here. Everything that I'm doing here is user generated. Everything that I'm providing here is questions that we get. It's not even my ideas here, it's your ideas, and I'm just responding to them. So also want to welcome the viewers that watch this show on replay. I know there's always many of you that watch this on replay. And of course, go and visit our website at intensivecareathome.com. So here's what we're covering today: NDIS basics, what it is, who qualifies, and how it works for medically complex children with disabilities. Level 2 versus level 3 NDIS support coordination, what's the difference, and which one does your child need? How to build an NDIS plan that actually funds 24-hour nursing, tracheostomy care, home ventilation. We cover the biggest mistakes families make, and how to avoid them. Plan reviews and appeals, what to do when your funding isn't enough. Real case studies from families we've supported or we are supporting, and we'll take your live questions at the end if there are any. But again, if you're watching this on replay, please type your questions below the video and I will get to them in another video or on one of my live streams. So let's get right into it. Before we talk about NDIS basics, what it is and who qualifies, before we go into that, just briefly, what do we do at intensive care at home? We provide tailor-made solutions for long-term ventilated adults and children at home, tailor-made solutions, i.e. intensive care nursing at home for long-term ventilated adults and children on BiPAP or CPAP, which is non-invasive ventilation. We provide tailor-made solutions, i.e. 24-hour nursing care for tracheostomy adults and children at home. We provide cough assist management at home, ventilation, weaning management at home, home TPN, home IV fluids, home IV antibiotics, home IV potassium, home IV magnesium infusions, port management, central line management, PICC line management, Hickman's line management, nasogastric tube, nasojejunostomy tube, PEG, PETch tube, IDC, SPC management, as well as palliative care at home. So let's start at the beginning, because I know some of you who are watching this and the NDIS is a completely new territory for you. So what is the NDIS? NDIS stands for the National Disability Insurance Scheme in Australia. It is an Australian government scheme that provides funding for people with permanent and significant disabilities to access the supports and services they need to live their lives. For children with ventilation plus minus tracheostomies who need ongoing nursing care at home, the NDIS funds nursing support, equipment, therapies, and specialist coordination if the clinical evidence is there to support that. Now, the NDIS is not a healthcare system, it is a support system. That distinction matters because the NDIS funds supports that help your child live at home and participate in life, not just medical treatment. And this also ties in with our philosophy, because one of the major differences what we do here at Intensive Care at Home is, instead of a child or an adult living in ICU, we want them to go home and live their life as independent as possible, have community access for children in particular, go to kindergarten, go to school, play with their peers, right? For us, it's all about living life as normal as possible, normalizing life, growing up with their siblings, growing up in their families with their parents. We want to normalize that, not medicalize that. We just provide the support that is needed to make that happen. So, who qualifies for the NDIS? To access the NDIS, your child must meet eligibility criteria. The key requirements are: your child must be under 65 years of age, your child must be an Australian citizen or permanent resident, your child must have a permanent and significant disability that affects their ability to participate in everyday life. And that is unfortunately the case for most kids with a tracheostomy or a ventilator. For a child with a tracheostomy, particularly a child who's ventilator dependent or who needs 24/7 intensive care nursing, eligibility is usually very clear. Tracheostomy is a significant permanent intervention. A ventilator is a significant permanent intervention. And if your child, because of that, requires ongoing high-level care that impacts their daily life and participation, they meet the disability criteria. So, what can the NDIS fund for your child? The NDIS groups funding into 3 budget categories. Number 1, core supports, including assistance with daily personal activities, which is where 24/7 nursing care is funded. Number 2, capacity building, including support coordination, therapies, and skill development. Number 3, capital supports, including assistive technology and home modifications. For children with tracheostomy on home ventilation, core supports is the most critical category because that is where funding for high-intensity nursing care lives. This is what makes it possible for your child to come home from the pediatric ICU or neonatal ICU and be cared for by ICU-trained nurses around the clock. Sometimes children in some hospitals, I know that in Sydney and in Melbourne, they might also be stuck on a respiratory ward, even though they're ventilated with a tracheostomy, to get them out of ICU. But they still need one-on-one intensive care nursing on those wards. It's just simply to free up the ICU bed. Key point here is, if your child is in the pediatric ICU or on a long-term weaning ward, and no one has mentioned the NDIS yet, or no one has mentioned intensive care at home yet, raise it now. The earlier you start the NDIS access process, the better. Do not wait until discharge is imminent. So go to intensivecareathome.com/NDIS to learn more about NDIS eligibility and how we help families apply. So now we go to level 2 versus level 3 NDIS support coordination. We talk about the core differentiation, and I want you to help understand why level 3 exists specifically for medically complex children with tracheostomies, ventilation, seizures, TPN, etc. Now, I want to talk about something that really confuses a lot of families, and honestly, even some service providers get this wrong, the difference between level 2 NDIS support coordination and level 3 NDIS specialist support coordination. Because if your child has a tracheostomy, is on a ventilator, or needs 24-hour nursing care, understanding this difference could mean the difference between a plan that works for you and a plan that fails. And unfortunately, we have seen that if a plan fails, it has resulted in participants, including children's deaths. That's how serious this area is and how serious we take it, because we know we are providing an intensive care bed in the community, and the staffing needs to be there, the funding needs to be there, the infrastructure just needs to be right to make it happen and make it happen safely. So what is level 2 NDIS support coordination? Level 2 NDIS support coordination, often just called support coordination, helps participants implement their NDIS plan. A support coordinator helps you find and connect with NDIS providers, assists with service agreements and managing your plan budget. They help you understand your plan and how to use it effectively, links you to community supports and services, monitors your plan, and flags when it's not working. Level 2 NDIS support coordination is appropriate for participants who have complex situations and need help coordinating multiple services. Many NDIS participants have level 2 funding in their NDIS plan. Now let's compare that to level 3 NDIS specialist support coordination, and let's talk about what is level 3 NDIS specialist support coordination. Level 3 NDIS specialist support coordination is a higher, more specialized level of coordination. It is designed for participants with extremely complex needs, clinical, social, or both, where coordination requires specialist knowledge, experience, and clinical insights. A specialist NDIS support coordinator, which is a level 3 NDIS support coordinator, must have qualifications and experience in working with complex disability and health conditions. At intensivecareathome.com, our level 3 NDIS support coordinators have NDIS support coordinator experience, extensive NDIS support coordinator experience, and they have clinicians around them. I'm a clinician. You know, we have, like I said, we have hundreds of years of intensive care nursing experience combined here at Intensive Care at Home. We have all the expertise in-house, whether it's the NDIS knowledge as well as the clinical knowledge. Like I said, all of our nurses are either adult or pediatric ICU nurses with decades of experience. Like I said, combined, we're employing hundreds of years of adult and pediatric intensive care nursing experience combined, because this matters enormously when coordinating care for a tracheostomy or ventilated child. Imagine it's coordinated by people without clinical knowledge. Like I said, the stakes are so high that people have died if you don't get it right. And I've publicly talked about this on my blogs here, that unfortunately NDIS participants have died, adults and children, because of failure of NDIS planners, but also of failures of some NDIS support coordinators, right? And everything that I'm saying here, I have evidence to back up. You know, very happy to talk to anyone who wants to continue that conversation about evidence where NDIS and NDIS support coordinators have failed without mentioning any names. A level 3 NDIS specialist support coordinator does everything a level 2 NDIS support coordinator does, but they also navigate complex clinical and medical systems alongside disability systems, advocate with hospital discharge teams, pediatric ICU teams and respiratory specialists, speak the clinical language as well as NDIS language, and understand ventilators, tracheostomies, medical equipment, and nursing acuity. They build plans that reflect genuine clinical complexity, not just generic disability support, help families through crisis plan breakdowns and emergency readmissions and avoid them with the right NDIS plan, with the right provider. They work with NDIS planners who may not understand pediatric tracheostomy care, ventilator care, seizure management to secure adequate funding. So, which level of NDIS support coordination does your child need? Well, if your child has a tracheostomy, is on a ventilator, or if they are tracheostomy dependent and need 24/7 nursing, even without a ventilator, your child qualifies for level 3 NDIS specialist support coordination. This is not optional. This is not an upgrade. This is the appropriate level of coordination for your child's complexity. And yet, I regularly see families whose children are on home ventilation or with a tracheostomy or both, with a level 2 NDIS support coordinator who has no clinical experience, no clinical team around them, no understanding of ICU discharge, and no ability to advocate effectively with the NDIS planner about why 24/7 ICU nursing is necessary. That is a setup for failure. And I want to make a critical distinction here. Level 2 coordinates services. Level 3 navigates clinical complexity and advocates for funding that matches that complexity. For a ventilated child with a tracheostomy or with a tracheostomy without ventilation, level 3 is absolutely essential. We at intensivecareathome.com, we provide NDIS level 2 and level 3 NDIS specialist support coordination, and you can find more information at intensivecareathome.com/NDIS. I also want to give you a real world example here that I'm not making up, that goes to show how important it is that you have the right NDIS support coordinator with the right level of understanding. And now you will also understand, once I've explained the example to you, why people have died. I had an NDIS support coordinator call me that we worked with one of our ventilated clients, who calls me the other day and says to me, "Oh, Patrick, you know that this particular client doesn't need nursing care." And I've told the NDIS. I said to the NDIS planner, "Well, you know, that might be your opinion, but you're not a clinician to make that assessment." And she said, "Oh yeah, intensive care at home has been lying all the way along. They've been making up things and overcharging an NDIS plan." I said, "Okay, if you think that's what you need to do, then that's your prerogative. But if funding or care is taken away by your actions, I will report you to the NDIS Quality and Safety Commission, because obviously you don't understand the clinical details of this particular NDIS participant." And once again, this is an NDIS support coordinator level 2 with no clinical background whatsoever. Cutting a long story short, she succeeded in taking the funding away, putting the client at the brink of a hospital readmission, putting the client at the brink of death, as a matter of fact. Now, the good news is that the family was working with us and our NDIS support coordinator directly, and we were able to turn this situation around at the 11th hour. But it just goes to show that incompetent NDIS support coordinators can put people's lives at risk. And people have died because of the incompetence of NDIS support coordinators, but also of the incompetence because of NDIS planners. And once again, I've got documented incidents around that I'm happy to share with anyone that's interested. Obviously, all de-identified, of course, but even the media might be interested in this. If you're watching this and you're from the media, I'm happy to talk to you, because the incompetence of some NDIS support coordinators and some NDIS planners have cost lives. So with us here, you're in good hands, because we understand NDIS, we understand the clinical, and otherwise we wouldn't exist. So again, level 3 NDIS support coordination is not optional. It's not an upgrade. It is the appropriate level of coordination if a child is on a ventilator with a tracheostomy, if a child is on a ventilator without a tracheostomy, if a child has a tracheostomy without a ventilator. So, critical distinction again, level 2 NDIS support coordinators coordinate services. Level 3 NDIS support coordinators navigate clinical complexity and advocates for funding that matches that complexity. For a ventilated child with a tracheostomy, level 3 NDIS support coordination is essential, not optional. It is life-saving. So Let's look at building an NDIS plan for ventilated or tracheostomy children. Let's get a bit more tactical. What does a good NDIS plan actually look like for a child with a tracheostomy on home ventilation, and how do you build one? What should be funded in your child's plan? A comprehensive NDIS plan for a ventilated child with a tracheostomy should include funding for high-intensity daily personal activities in core supports. This is the category that funds 24-hour intensive care nursing. The NDIS recognizes that some participants need assistance with daily personal activities at a very high intensity, meaning they cannot be left alone safely. They need immediate support with breathing, suctioning, repositioning, feeding, and monitoring. For a child on a ventilator with a tracheostomy, this typically means funding for ICU-level nursing support for most or all hours of the day. The exact hours funded will depend on your child's clinical needs. Most children need 24/7. Some might need waking hours only, depending on whether they are not having a tracheostomy. If children are not having a tracheostomy but are BiPAP, CPAP ventilated, need a cough assist, they mainly need nurses when they are ventilated, but some of them might also have a nasogastric tube, right, or a nasotracheostomy tube. That's when they also need 24-hour nursing care, right? And again, many NDIS support coordinators don't understand that a child or an adult with a nasogastric tube or a nasotracheostomy tube also needs a nurse 24 hours a day. We've got some case studies around that on our website where we looked after clients at home on nasogastric or nasotracheostomy tubes. In any case, all of that is easily clinically justifiable with evidence from, and now it also gets important, take some notes, medical evidence from, it needs a doctor's letter to clearly state that a child needs 24-hour intensive care nursing because of their disability leading to tracheostomy, ventilation without tracheostomy or tracheostomy. It needs to clearly state 24-hour specialist nursing with CCRNs. Needs a nursing assessment stating the same, that the child needs 24-hour nursing care with specialist nurses, CCRNs. Needs a physiotherapy assessment, needs to say the same, that the child needs 24-hour intensive care nurses. Needs a speech therapy assessment, needing to say the same, that the child needs 24-hour intensive care nurses. Needs the functional capacity assessment by the OT, also saying that the child needs 24-hour intensive care nursing because of their disability leading to ventilator, tracheostomy, ventilation without tracheostomy, tracheostomy without ventilation, right? All reports need to be aligned and need to be saying the same, and that won't be an issue if the clinical realities are met. And as we just discussed, your child should have level 3 NDIS specialist support coordination funded in their capacity building budget. This is typically a set annual amount, often $10,000 to $20,000 per year for complex NDIS participants, though this varies based on need. Number 3, assistive technology and equipment, capital supports. Some equipment may be funded through the NDIS, though much of your child's medical equipment will be funded through the healthcare system. NDIS may fund things like communication devices, specialized seating, home modifications for accessibility, or backup equipment if there are any gaps in medical equipment provision. This needs to be assessed on a case-by-case basis. Number 4, therapies, capacity building. If your child receives physiotherapy, occupational therapy, speech therapy, or any other allied health services, these can be funded in the capacity building budget. Therapy funding is critical for children with tracheostomies, children on ventilation, children with active seizure management, particularly around swallowing, communication, and motor development. So, how much funding should your child's NDIS plan have? This is the question every family asks, and the honest answer is, depends on your child's needs, but I can give you some context. A child who needs 24-hour ICU level nursing care at home will have a very high value plan in the eyes of the NDIS. However, keep in mind that high value plan cuts the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $10,000 per bed day. So yes, your NDIS plan for your child will be, roughly maybe $1 million, $1.5 million a year. Compare that to an ICU bed with a minimum of $3 million a year, right? So don't let the numbers scare you off. because someone else will be paying a lot more if you don't get that high value plan. And it's just perceived high value, no more than that. And it's pocket money often for the government, because in the meantime, the government is paying $3 million per year for an ICU bed. So if anything, we're creating a win-win situation here for all stakeholders. So, $3 million a year for an ICU bed sounds enormous. $1.5 million for intensive care at home sounds much better. It doesn't sound enormous, because on top of that, for anyone of you watching this that are watching from a hospital, we're freeing up your ICU bed, right? Again, it's a win-win situation. And your child needs 24-hour nursing care regardless whether they're in a hospital or at home. So you might as well make it 50% less of that cost, and you might as well be at home with your family. You might as well stop going to hospital, stop going to the pediatric ICU, and we might help the ICU, might help them as well to free up their in-demand and very precious ICU bed. So, and the NDIS is actually designed by legislation to fund this level of support for children who genuinely need it. Your child is not asking for too much. Your child is asking to get the cost of their care down, but to be in a much better environment. Once again, it's a win-win situation. Your child's needs are what they are. And I can tell you from experience, once again, that if this is not being funded, children and adults have died. And you don't want to be a statistic. You want to live your life, and you want to live your child's life. So what does the NDIS look at when assessing plans? The NDIS assesses reasonable and necessary supports for your child. This means it's 24/7 nursing reasonable at home and necessary to keep them safe at home. For a ventilated child with a tracheostomy, the answer is always yes, for exactly the reasons that I mentioned. Roughly $3-4 million a year for an ICU bed will bring that down to $1 million, $1.5 million. No-brainer, win-win situation, right? How do you build the NDIS plan? Building a strong NDIS plan for your child requires medical evidence from your child's pediatric team. Could be ICU consultant, could be pediatrician, could be respiratory physician, could be from the respiratory team, and the pediatric ICU team stating your child's disability and clinical needs, the level of nursing support required, which in all cases will be 24-hour nursing care, and the permanence of their disability, functional capacity assessments showing how your child's disability impacts on their daily life and participation, a well-documented support needs assessment that clearly articulates why your child needs high-intensity supports and 24-hour intensive care nurses. It also needs a support coordinator or specialist support coordinator who understands your child's clinical complexity and can advocate effectively during NDIS planning meetings. This is where intensive care at home's Level 3 NDIS specialist support coordination makes a huge and tangible difference. We prepare families for planning meetings with the NDIS. We gather the right evidence. We speak to planners in language they understand, and we fight for plans that genuinely reflect your child's needs. And once again, to summarize here and write this down, you need a doctor's letter to support and clearly state 24-hour nursing care with specialist CCRNs is needed. The same needs to be documented in an independent nursing assessment. The same needs to be documented in a physiotherapy assessment, in a speech therapy assessment, and in the functional capacity assessment through the OT. Now, let's now look at common mistakes and how to avoid them. Now we talk about what to families, what not to do based on what we've seen fail in the past. So let's talk about the common mistakes I see families make when navigating the NDIS for the first time, because if I can stop even one family from making this mistake, this segment is absolutely worth talking about. Mistake number one, waiting until pediatric ICU discharge to start the NDIS process. The NDIS access process takes time, often several months from application to approved NDIS plan. If you wait until your child is ready to be discharged from the pediatric ICU to start applying for the NDIS, you will inevitably delay discharge. Or worse, your child will be discharged without adequate funding in place, and you will scramble to manage at home without the supports you need. Start the NDIS access process as soon as it becomes clear that your child will have ongoing care needs after discharge. Ideally, start while your child is still in the pediatric ICU. The NDIS can approve access for children who are still in hospital. Mistake number 2, accepting the first plan without question. Many families receive their first NDIS plan, see a large number and think this must be right. But when they try to implement the plan and book the supports their child needs, they discover the funding is inadequate. Your goalpost doesn't need to be the $1.5 million a year you need. Your goalpost needs to be the $3 million per year. $3 million per year the taxpayer pays for your child's ICU stay, right? And that is your goalpost, and bring that down by 50% and make it a win-win situation by you going home, by your child going home, by freeing up an ICU bed. It's a win-win situation. Also, don't assume the first NDIS plan is correct. Review it carefully with your NDIS support coordinator. If the plan doesn't fund the hours of nursing your child's needs, request a plan review immediately. You have 90 days from when your plan is approved to request a review without needing new evidence. Mistake number 3, choosing an NDIS support coordinator who has no clinical experience and no clinical team around them. I cannot stress this enough. If your child is medically complex, tracheostomy, ventilator, high-level nursing needs, seizures, TPN, you name it, or nasogastric tube, PEG tube, you need an NDIS support coordinator who understands clinical complexity, or at least has a team around them who understands clinical complexity. A well-meaning NDIS support coordinator with no healthcare background will struggle to advocate for your child's funding because they do not understand the clinical justification for 24/7 intensive care nursing at home. Choose a level 3 NDIS specialist support coordinator with clinical experience or with a clinical team around them. It is worth paying for if the NDIS hasn't funded it yet. And we have those NDIS support coordinators here at Intensive Care at Home. Mistake number 4, not documenting everything because the NDIS is an evidence-based system. And we are an evidence-based service. If you cannot demonstrate your child's needs with documented evidence, the NDIS will not fund supports. This means keep copies of all medical reports, discharge summaries, and specialist letters. Document all incidents, hospital admissions, and any deteriorations in your child's condition. Track the hours of care your child currently receives and what happens if that care is reduced. This documentation becomes critical when you need to request a plan review or appeal a decision. Mistake number 5, not using all your plan funding. Some families are hesitant to use all the funding in their NDIS plan because they worry it will look wasteful or that future plans will be reduced. Once again, keep in mind, if your child is in hospital in ICU, someone else will pay double or triple. So spend all your NDIS money because you're saving the taxpayer money by doing so. So not spending all your money is the wrong approach. If the NDIS has assessed that your child needs a certain level of support and it's funded, use it. Unused funding signals to the NDIS that your child didn't need that level of support and your next plan may be cut. Use your plan, use the supports your child is entitled to. That is what the funding is for. Biggest mistake of all, trying to navigate the NDIS alone without expert guidance. The system is complex, the language is confusing, and the stakes are too high. Get help. Okay, let's now look at plan reviews, NDIS appeals, fighting for more. In this segment, I want to empower families. I will teach you how you can fight back when plans are inadequate and how we can help you every step of the way. So, what do you do when your child's NDIS plan is approved, but it's inadequate and it's not enough? Maybe the hours of nursing funded don't cover overnight or daytime support. Maybe the plan doesn't include level 3 NDIS specialist support coordination. Maybe the total funding is so far below what your child needs that it's not even close to workable. So what do you do? Well, quite simple. You fight back, and we can help you with that. We will be alongside that fight with you every step of the way. And here's how. Number 1, request an NDIS plan review. You have the right to request a review of your NDIS plan at any time. There are 2 types of reviews. A scheduled plan review. This happens automatically when your plan is due to end, usually annually or every 2 years. Then there's unscheduled plan reviews. You can request this at any time if your circumstances have changed or if your plan is not meeting your needs. If your child's first plan is inadequate, request an unscheduled review immediately. Do not wait until the scheduled review date. Provide new evidence of your child's needs, medical reports, nursing logs, incident reports, and clearly explain why the current plan is not reasonable and necessary. Number 2, internal review of decisions. If the NDIS makes a decision you disagree with, such as rejecting your plan review request or reducing funding, you can request an internal review. This is a formal process where the NDIS reviews the decision and the evidence again. You have 3 months from the date of the decision to request an internal review. Number 3, external review, which is the Administrative Appeals Tribunal, the AAT. If the internal review does not resolve the issue, you can appeal to the Administrative Appeals Tribunal, the AAT. The AAT is an independent body that reviews NDIS decisions. Many families win at the AAT when they have strong evidence and good representation. The clients that we've had at the AAT all had won their cases because the evidence for someone on a ventilator with a tracheostomy is just undeniable, that they need 24-hour intensive care nurses at home. Appealing to the AAT can feel intimidated, but for families whose children need high-level support and 24-hour nursing care at home to keep them alive, keep them safe, and get them to live a normal life, and whose plans have been unreasonably cut or denied, the AAT is often the pathway to justice. We have supported families through AAT appeals and won. Number 4, get expert help. Navigating NDIS plan reviews and appeals is not something you should do alone. An level 3 NDIS specialist support coordinator can help you gather evidence, write submissions, attend meetings, and advocate for your child. If you're going to the AAT, consider engaging an NDIS advocate or lawyer who specializes in NDIS appeals. And if you're looking for a lawyer, please reach out to us. We can help you with connecting you to a lawyer. Needless to say that at Intensive Care at Home, we help families prepare for plan reviews, challenge inadequate decisions, and fight for funding that matches their child's clinical needs. We speak the NDIS language, we speak the clinical language, we know what evidence matters, and we do not back down, ever, right? And like I said, unfortunately, we can also give some postcodes around where NDIS participants have died. That was preventable because of NDIS failures and NDIS support coordinators' failures. And never forget that you have rights. The NDIS is not doing you a favor by funding your child's support. Your child has a legal right to reasonable and necessary supports. If those supports are being denied, you have every right to fight back. Do not think that any of the NDIS bureaucrats making decisions will pay for your child's need out of their pockets. It's taxpayer-funded money, but it's designed to save money because otherwise a hospital bed is occupied and that will cost a lot more. Like I said, at least double, sometimes triple and more. Okay, let's now look at some real case studies of children intensive care at home has supported through the NDIS. For example, there is a child, she's a young adult now, but the child first went to the AAT, has a very complex neurological condition, and has seizures every day, has a complex seizure management plan, needs high flow oxygen, needs BiPAP, needs CPAP, needs APAP. And, the NDIS at the time was trying to deny funding, but obviously with once again, and please write this down, doctor's letter to clearly state the child needs 24-hour nursing care with critical care trained nurses, independent nursing assessment stating the same, physiotherapy assessment stating the same, speech therapy assessment stating the same, and that's all then finalized in a functional capacity assessment in an OT, all saying the same. Now, this case actually went to the AAT at the time, and of course, the family got their funding for their child. Also, what's interesting to note about this child is, 10 years ago, we've worked with the client for 10 years. That was way before the NDIS, when it was still Department of Health funded. Interesting to know that at the time, the child was under palliative care in a children's hospital. And, the hospital was expecting the child to die, but then she got 24-hour nursing care. And 10 years later, she's still here, so with a good quality of life. So really important. Then we had another client that went to the AAT a while ago. That was actually an adult client, also ventilated tracheostomy, with also a neuromuscular condition, I should say. Again, evidence was provided, case went to the AAT, and client got the funding. What's interesting to note here is that most cases that go to the AAT will actually not go to the final verdict. So what I mean by that is the evidence is so overwhelming, right, that the NDIS will settle the day before the court hearing, because the NDIS knows the AAT will decide in a client's favor, right? And the NDIS will settle the day before so that it doesn't get published in the media. But we see it all the time, of course, that these things happen. We also had another adult client a few months ago, actually, also went to the AAT. That was for home TPN. For those of you who don't know what's home TPN is intravenous nutrition. It's for someone with gastric, a paralyzed stomach, with gastroparesis, with digestion issues. They can't eat, they can't drink, they need TPN. They need a central line, a PICC line, a Hickman's line, or a port, right, to have TPN infused, right? And for that particular client, also went to the AAT, and NDIS was trying to deny critical care nurses for TPN connects and disconnects, right? Can only be done by critical care trained nurses, right? NDIS story can be done by disability support workers. Well, patient would die if that was the case. Cutting a long story short, again, the NDIS gave in the day before the verdict was due. What that's telling you is the NDIS is wasting a lot of time, resources, money on lawyers to fight what patients and clients are entitled to. Why are they doing it? They probably still save money along the way. They think we haven't seen that because those clients still need funding in the meantime. Because if they don't get funding, they'll die, right? So, but most cases have not gone to the AAT or to the ART. Most cases have been funded once the evidence is there. It all comes down to evidence. So, next steps, go to intensivecareathome.com. Call us on one of the numbers on the top of our website. Send us an email to info@intensivecareathome.com. We'd love to work with you. Once again, we provide level 2, level 3 NDIS support coordination. But from a nursing perspective, we provide 24-hour intensive care nursing for long-term ventilation with tracheostomy for adults and children, long-term ventilation on non-invasive ventilation such as BiPAP, CPAP for adults and children, tracheostomy care at home without ventilation for adults and children, cough assist management at home, ventilation weaning management at home, home TPN, home IV fluids, home IV antibiotics, potassium, magnesium infusions at home, central line, PICC line, Hickman's line, port management at home, nasogastric tube, nasojejunostomy tube, PEG, PETch tube, SPC, IDC management, and palliative care management at home. We love to work with you. We are very passionate about what we do. and we would love to work with you. Go and reach out to us at intensivecareathome.com. I do these YouTube lives every Sunday at 10:30 a.m. Sydney, Melbourne time, which is 6:30 p.m. Eastern Standard Time in the US, 3:30 p.m. Pacific time in the US. I do apologize to my American audience that in the last couple of weeks we've focused on Australia only, but I will be back with more general topics that are applicable to our much appreciated US audience as well. And keep your questions coming. Like the video, subscribe to my YouTube channel, click notifications, and share this video with anyone that will benefit from this. Have a wonderful week and take care for now.